And today we're here to talk about scoliosis. But before we get started, we'll talk about the basic anatomy of the spine. We have the T-spine here in our clay model, and it's 1 through 12. Then we have the L-spine at the bottom, which is 1 through 5. We have the spinous process, you can see the transverse process. And in scoliosis, the curve usually happens in the T thoracic and the L lumbar spine area. It's more common to have an S curve from right to left. And Amanda and Emily will cover the pathology of scoliosis.
Okay, so scoliosis, there are 3 types, and it is idiopathic, which is the most common, congenital, and acquired. It can also be classified as primary and secondary. Primary would be the idiopathic, and secondary would be neuromuscular, congenital, developmental, or tumor associated. Okay, idiopathic scoliosis accounts for 80% of all cases. It is predominantly in females with a ratio of 7 to 1. It can be subclassified into infantile, juvenile, and adolescent, depending upon the age of onset. The most common of these is adolescent, which is the most common type of idiopathic scoliosis in the United States. Children with scoliosis have a spine that curves from side to side like an S or a C. Small curves generally don't cause problems. Bigger curves can be visual and cause discomfort. A curved spine can cause the body to tilt to the left or right. One shoulder blade may be higher than the other, or the waist may be uneven, with a tendency to lean to one side. If the curve is severe, it can affect breathing and heart function and lead to damage in the joints of the spine and pain during adulthood.
X-ray to diagnose scoliosis. The doctor is often going to order x-rays to measure the curvature of the spine. The angle of the curve is going to be measured in degrees on the x-ray, and it will help the doctor decide whether treatment needs to be made or not, and if so, how. This is an AP x-ray of a patient with scoliosis. It's actually my x-ray. And you can see that it's a slight S curve. The x-rays also will help the doctor determine how mature the child's skeleton is, and he may have them be repeated at regular intervals, maybe 3 to 12 months, to check whether the curve is growing or not. Usually 2 pictures are taken in a scoliosis exam. They have one from the back, which is what they're changing the routine from AP to PA, and one from the side is going to be lateral. And then sometimes other views will be taken where the person is bending. That's just dependent on the doctor. There's different patterns of the curve. It's generally described as the location. Scoliosis is generally described as the location of the curve or the curves. And to measure the curve, the method that is most commonly used is called the Cobb method. In order to measure the curve, though, the type of curvature present must first be determined. The curvature may be acute, which is small, like this one here. But however, it's more often smooth and arcuate, which is like a bow-shaped. The Cobb angle is measured between the superior end plate of the proximal end vertebrae and the inferior end plate of the distal end vertebrae. And usually an increase in the Cobb angle by 5 degrees or more per year indicates that the scoliosis is progressing. Okay, so we're going to talk about treatment now. The treatment for scoliosis is determined by the severity of the curve, the likelihood of curve progression over time, and the patient's perception and deformity just observe the patient over about every 3 to 12 months and make sure that the curve isn't progressing. Bracing, which involves using a back brace to keep the spine straight, and surgery. All options are available for the treatment of adolescent idiopathic scoliosis. Bracing has no role in adult idiopathic scoliosis because usually the skeletal system is mature by then. But surgery is the only option for congenital scoliosis and other forms of scoliosis with known underlying causes when the intervention is necessary.
So regular observation is maintained if a patient with adolescent idiopathic scoliosis has a curvature with a cob angle of less than 20 degrees, or a skeletally mature patient has a curvature with a cob angle of less than 30 degrees at presentation. And the follow-up is 4 to 12 months.
Okay, now we're going to talk about bracing. The aim of bracing is to avoid surgery. Bracing is considered for curves with a cob angle of 20 degrees to 45 degrees in patients with adolescent idiopathic scoliosis. For curves of 20 degrees to 30 degrees, bracing is commenced only when progression of 5 degrees or more occurs between consecutive visits. However, when a patient is evidently skeletally immature and presents with a 30 to 45 degree curve, bracing is commenced at the very first visit. And we have an example of a brace.
This is actually my brace from when I had scoliosis as about 13 years old or so. I had to wear it 2 years in junior high. And it's made out of plastic and it has air holes in it. And in the back, it's strapped with Velcro and buckles. And it is not the most comfortable thing to wear at all. We usually have a cob angle of 45 degrees or more at presentation. Surgery is usually indicated in skeletally immature patients with that angle also. The surgery is also going to be recommended for patients with curve progression without the use of a brace and for those who cannot tolerate the use of a brace. For skeletally mature patients, surgery is recommended again for curves with a cob angle of 45 degrees or more, and given that the curve progression is accompanied by some pain. Progressive congenital scoliosis, in which the involved spinal segment is usually too short or too inflexible to respond well to bracing, is also treated well surgically. The goals of surgery in idiopathic scoliosis patients are as follows. The primary goal is to prevent curve progression by achieving solid bone fusion of the involved vertebral segments. The secondary goals are curve correction, trunk balance restoration, sagittal contour preservation, while leaving as many mobile segments in the lumbosacral spine as possible. Goals of surgery in general. For non-idiopathic scoliosis, the goals of surgery depend on the underlying cause. And in the presence of degenerative scoliosis, the goal is primarily spinal decompression and trunkal balance correction. Whereas in neuromuscular scoliosis, the goal is curve correction. The objectives of curve correction in neuromuscular scoliosis are to restore seating, balance, to ease wheelchair use, to control pain, and to support the trunk so as to reinforce respiratory function. To optimize treatment outcomes, surgeons make every effort to spare mobile segments of the lower lumbar region when performing fusion so as to minimize the loss of lumbar lordosis and avoid post-operative lower back pain. Lower back pain occurs in most patients who undergo fusion beyond the L3 level. the doctor will usually have the patient bend over, and they'll see if the right or left shoulder blade is more elevated than the other. This was my spine after I had the scoliosis surgery. You could tell there's obviously a major change in the curve of my back. My doctor did not use the whole spine. He just went with my thoracic spine, and that was so I would be more mobile later in life. And usually, I think most doctors try to do that so they won't. All right, this is a severe case of scoliosis, and this was before the scoliosis surgery. You can see that this patient had a very large curve. And this is the same patient's spine after surgery, and it was a major improvement.
In conclusion, if scoliosis is neglected, the curves may progress dramatically, creating significant physical deformity and even cardiopulmonary problems with especially severe curves. Currently, scoliosis is treated successfully by special braces and surgery or by combinations of both